Hello everyone. Today we are going to learn an interesting and informative session on handling a patient in mechanical ventilator. You all will be wondering, right, how the mechanical ventilator will look like and how to take care of a patient with the mechanical ventilator and all. So in this session you are going to have a clear picture of handling the patient in mechanical ventilation, what are all the setups involved in mechanical ventilator and all. So are you all ready to listen to this interesting session? Let's move on. Coming to the introduction. What is mechanical ventilation? Mechanical, when the patient is unable to take their breath manually, they prefer using the respiratory support, which is through ventilator. So that is called as mechanical ventilation. So in simple terms, we call it as mechanical ventilation is a life support technique used to assist or replace spontaneous breathing. So which I have already told. When the patient unable to take the breath spontaneously or normally, when they have any difficulty to take their own breath, they need some sort of machine which is called as mechanical ventilator. So mechanical ventilation is a life support technique used to assist or replace spontaneous breathing. Clear? So this is the simple term for mechanical ventilation. What does it do? It delivers oxygen to the lungs and removes carbon dioxide. Clear? Like what our lungs do, the same concept this mechanical ventilation will do. So it delivers oxygen to the lungs and it removes carbon dioxide from the lungs. So this is the main function of the mechanical ventilator. So what are all the patients we use this mechanical ventilation? So commonly used in ICU patients with respiratory failure. Clear? So in ICU only we will have a critical patients, right? So it is very commonly in ICU patients with respiratory failure. So nurses who play a vital role in monitoring airway and preventing complication, they play a major role in handling this mechanical ventilator. So this is the simple definition and the introductory overview for the mechanical ventilation. Once again I'll repeat, mechanical ventilation is a life support technique used to assist or replace the spontaneous breathing. So whenever a patient unable to take their own breath spontaneously, they need some sort of artificial device which is called as mechanical ventilator, and the ventilation through the mechanical ventilator is called as mechanical ventilation. What does it do? It delivers oxygen to the lungs and remove the carbon dioxide. Just in simple terms we can say it as it does the function of the lungs. What the lungs will do? We will take the oxygen, will enter into the lungs and the lungs will removes the carbon dioxide. Same way the mechanical ventilator will act. It delivers oxygen to the lungs and it removes the carbon dioxide. So in which all the patient we use? We use commonly in ICU patient with respiratory failure. So nurses who play a pivotal role should be well versed in handling this mechanical ventilator in order to bring out successful clinical outcome. Clear? What are all the indications for mechanical ventilation? In the introduction itself we saw that respiratory failure. So these are all some of the different indications. In these situations we will switch over to mechanical ventilation. First and foremost is the acute respiratory failure. In case of respiratory arrest, we can able to bring back the secretion through, we bring back the respiration through CPR technique. In case of failure, in case of respiratory failure, obviously we have to switch over to mechanical ventilation. Second condition is severe pneumonia. We have different levels of pneumonia. No, pneumonia will affect one part of the lobe or maybe the two part of the lobe. In case of severe pneumonia, definitely we have to switch over to mechanical ventilation. The third is the ARDS, very common in preterms or the neonates, acute respiratory distress syndrome. When the baby is in distress or acute respiratory distress syndrome, definitely for time period we have to put the baby on mechanical ventilation. Once the baby has the capacity to take their normal respiration or the respiratory distress settles, we will slowly wean the baby from the ventilator and then make the baby to breathe spontaneously. What is the fourth thing? COPD exacerbation. What is the meaning of COPD? Chronic obstructive pulmonary disease. I just want to tell you all one thing. We are all very familiar with the term called cold, right? C-O-L-D. This cold is termed as chronic obstructive lung disease, whereas this COPD is termed as chronic obstructive pulmonary disease. So when the COPD exacerbate or severe form of COPD, we have to put the patient on mechanical ventilator. Then the next one is the neuromuscular disorders. In case of severe myasthenia gravis or neuromuscular condition, the lung muscles or the smooth muscles which is present in the chest will be unable to take their own breath naturally. So in such situation, in case of this neuromuscular condition, we will temporarily put the patient on mechanical ventilator, and then in later stage they may need some tracheostomy ventilation also. So this is one of the very most severe cases, so neuromuscular conditions. And then next is the post-operative respiratory support. You would have seen some sort of major surgeries like cardiopulmonary bypass, that is CABG surgeries, major neurosurgeries, craniotomy, craniectomy, and some sort of other GI surgeries. What they will do, we will make the patient in sedation mode. In sedation mode, whether the patient will be able to breathe? No, not at all possible. In that situation, we will put the patient on this mechanical ventilator for temporary period, maybe for 1 day or 2 days, and then slowly wean it off, and then we will make the patient to breathe spontaneously. So, in case of immediate temporary post-operative respiratory support. Then cardiac arrest patient. Post cardiac arrest, once the cardiac rhythm if we have reverted, we will put the patient on this mechanical ventilation for some time till the patient gets hemodynamically stable. So in case of post cardiac arrest status, we will put the patient on mechanical ventilation. Clear with the indication? We have several indications for making the patient to go into mechanical ventilation. First and foremost is the respiratory failure. Second one is the severe pneumonia. Third one is the ARDS, especially seen in neonates or preterm neonates, etc. Then COPD exacerbation in case of old age patient. Then neuromuscular condition, for example, myasthenia gravis, severe Parkinsonism, and other autoimmune neuromuscular disorders. Then post-operative respiratory support, say for example CABG or major neurosurgery, post-operatively we will put the patient on mechanical ventilator at the safer side. Then cardiac arrest patient, that is post-cardiac arrest. Clear with the indications? Any doubt so far? Okay, let's move on to the next thing. Types of mechanical ventilation. So what are all the types of mechanical ventilation we have? We have two types, invasive ventilation and non-invasive ventilation. Clear? What do you mean by invasive ventilation? Invasive, the term itself says whether any items or any devices which go into the body. Say for example your IV cannula, your NG tube, your tracheostomy tube, your catheterization, Foley's catheterization, all these things are invasive procedure, right? Some external device is going into the body. So we call it as invasive. So invasive ventilation is nothing but externally we will put the ET tube into the respiratory tract. So your UT tube or tracheostomy tube, when it goes into the lung cavity, we will call it as invasive ventilation. Non-invasive ventilation means what? Non-invasive, without any invasive lines or tubes or catheters going into the lung cavity. We have two types in non-invasive. One is CPAP and BiPAP, continuous positive airway pressure and bilevel positive airway pressure. So in these two cases, we will not put the patient exactly on ventilator. We will use the ventilator setup. With the help of BiPAP mask or CPAP setting, we will ventilate the patient. So non-invasively we give ventilation. Clear with the two types of mechanical ventilation? Once again I repeat, one is invasive ventilation where the invasive tube which goes into the lung cavity either through ET tube or tracheostomy tube, which is called as invasive ventilation. And non-invasive ventilation is without any invasive tubes or catheters going into the lung cavity. Externally we will give ventilation. Say for example your CPAP and BiPAP. We will use only the ventilator setting as an external source. Clear with the two things, invasive and non-invasive? Okay. Next is the very important and interesting panel, which is components of ventilator. So a normal ventilator, what are all the setting will be there in normal ventilator? One is your control panel, next is your breathing circuit, humidifier, oxygen supply, alarm system and patient interface. I'll explain it to you one by one. One is the control panel. Control panel is nothing but the panel which is present in the ventilator. Have you all have seen any idea of ventilator? Or when you go to clinical setup or when you practice as a nurse, just have an opportunity to look at the ventilator setting. The tubes, the knobs will be there, which is called as the control panel, where we have different types of setting. Tidal volume, minute volume, rate and all those things, where all the settings will be present in the ventilator is called as control panel. Next is what? Breathing circuit. What is breathing circuit? The circuit which is coming from the patient bedside. So from the ventilator, from the ET tube, some sort of circuit will come. That circuit will come and go connected into the ventilated part. Okay. So from the patient ET tube, there will be a tube will be coming. In that tube, we will connect this circuit and that circuit connects the patients and the ventilator. Are you all clear? So breathing circuit is nothing but the circuit which connects the patient and the ventilator. Third one is the humidifier. Like how we have a O2 humidifier, same way we have humidifier for ventilator setup in order to humidify the oxygen. Where if you connect the dry O2, what will happen? The mucous membrane of the entire respiratory tract will get irritated and that also may cause some barotrauma or any trauma into the lung passage. So definitely we have to humidify the oxygen which is coming from the oxygen chamber, humidify it and then connect it to the patient side. Next is what? The oxygen supply. Like how we have the wall mount oxygen supply, we have a oxygen supply getting connected in the ICU setup. So oxygen supply, from the oxygen supply it go to the humidifier, then to the breathing circuit, then to the patient system. Okay, next is the alarming system. We have different types of knob which is presenting in the ventilator called as alarm system. When the settings, if we set some sort of setting in the ventilator, right? When the settings goes above or below the settings, the machine will give some sort of alarm in order to make us inform that the patient is going on some apnea or some hypopnea or some hypercapnia and some sort of other things. So alarm system used to indicate where the patient is having some sort of disturbance in the breathing part. So the alarm system plays a major role. So this is also available as a knob like thing in the ventilator, mechanical ventilator. What is the last one? Patient interface. The name itself suggests interface. So your UT tube and the tracheostomy tube is the patient interface through which only it connects the machine and the patient side, right? So that is the patient interface. Clear? Clear with the components. One is the control panel which is available in the ventilator machine. So in the control panel we have various types of knobs like this, like minute volume, tidal volume, respiratory rate, which the anesthetist will do all sort of setting. So this control panel will be available in the ventilator machine. Second is your breathing circuit, which is nothing but the Bain circuit. You all would have seen the ventilator tubings, right? So this breathing circuit will connect the ET tube to the mechanical ventilator. Third is your humidifier, which is to connect the humidified oxygen, to humidify the oxygen before supplying to the patient. We have a O2 source or O2 supply. We have some alarm system. So when the patient setting goes above or below than the settings, the machine, the ventilator will give alarm in order to trigger the patient or in order to make us informed to go and check the patient's condition. Then patient interface. Interface, the name itself indicates it is the connecting part between the ventilator and the patient. So your UT tube and the tracheostomy tube is the patient interface. Clear with the components of this ventilator? Okay. Next is the interesting thing. First one is the assist control. So this is the ventilator modes. What are all the ventilator modes? We have 4 different modes available in mechanical ventilator. Whatever model we use, whatever models, whatever designs the ventilators may be, we have 4 common modes available in the ventilator. Okay. First is the assist control or volume control mode. What it mode indicates? In this mode, the machine only will take over. Patient will not take any sort of breath. Only the breath will be in the control of the machine. The machine only will give the ventilation, will give the breath, patient will not take any sort of breath. That is called as assist control or volume control. Next is the SIMV, synchronized intermittent mandatory ventilation. What do you mean by that? So in this mode, half amount of breath will be given by the ventilator and half breath will be taken by the patient. Usually during weaning phase, we will put the patient in SIMV mode. So ventilator will give half breath, the patient will give half breath. Okay. So this is the SIMV mode, synchronized intermittent mandatory ventilation. Then pressure support ventilation, this is the third mode. In this mode, the patient will take this whole breath, only the machine will support. So whenever he is not breathing, the machine will just support it. So the patient will take his own breath, only the support will be given from the ventilator. That is called the pressure support mode, and this is the mode we will put before extubation. So during weaning phase, just before extubation, we will put the patient on pressure support. So the patient will take the breath there on their own, and during any deviations or any support if he requires, the machine will just support, which is called as pressure support mode. And CPAP mode is nothing but continuous positive airway pressure mode. So this is also similar to pressure support mode, only the machine will support. Rest of the respiratory part will be taken over by the patient. Clear with the 4 different modes of ventilator? One is assist control, next is your SIMV, synchronized intermittent mandatory ventilation, next is your pressure support, and the last one is the CPAP mode. Okay. So what is assist control? Once again I repeat, assist control or volume control is nothing but full the ventilator will take over. That only will give the ventilation to the patient. Patient will not take any active ventilation. Patient will be in complete sedation. After major cardiothoracic surgery or major head injury, we will put the patient on ventilator. No, that time we will put the patient on assist control mode. Okay, patient hemodynamically stable means we will switch over to next mode is called as SIMV mode. Half the ventilator will take the breath, half the patient will breathe. Pressure support, the patient only will take the breath, only the machine will just support him. CPAP is also similar to pressure support. Clear about the different modes available in ventilator? Okay. Next, our important point is nursing assessment. What are all the things you have to assess when the patient is on ventilator, mechanical ventilation? First and foremost thing is the monitor respiratory rate and pattern. Obviously, patient what we are doing in this condition. So we have put the patient on respiratory support, right? So definitely we have to assess the respiratory rate and pattern. So we have to check whether there is spontaneous breath there or not, whether the respiratory rate is normal, whether the pattern is good, all those things you will be assessing. Next is checking SpO2 and ABG values. Definitely, once you intubate the patient, definitely you have to check ABG value, and obviously you have to check saturation level. What is the normal saturation level? It should maintain more than 95%. And the ABG value, you have to look for whether any acidosis is there, respiratory acidosis, respiratory alkalosis. In order to assess that, you have to definitely check ABG values. Next is observe chest expansion. You have connected the patient to ventilator setup. What we have to assess, whether the chest movement is there or not, whether the lung is taking the oxygen which is being delivered from the ventilator or not. So we have to assess using this chest expansion. Like how we assess the respiratory rate for a normal patient by using chest movement, same way you have to assess for chest expansion when the patient is on ventilator as well. Next, assess breath sound. Definitely you have to auscultate the breath sound, whether it is any stridor is there or any whistling sound is there. You have to auscultate the breath sound. One of my internists always used to tell, the stethoscope should be at the bedside of the patient who is in mechanical ventilator, because at any time we may think we may have to assess the breath sound. So that time you cannot go and search the stethoscope anywhere, right? So definitely you have to assess the breath sound using auscultation methods. Then check the level of consciousness. So in between we have to make the patient whether he is taking any spontaneous breath or not. You have to check the conscious level. If the patient is conscious and the ABG values are all okay, you will then plan for the patient's extubation. Monitor vital parameters again and inspect ET tube for position and fixation. Very important point. We have to inspect ET tube for its position and fixation. We will fix the ET tube within some other position, and also we have to check the pressure which is available in the bulb. Often we have to check whether the bulb is inflated or not. When you do suctioning or after suctioning, before suctioning, you have to check whether the position is right and the bulb is properly inflated in order to prevent accidental ET tube removal. So these are all some of the nursing assessment you have to do for a patient who is on mechanical ventilator. Clear? One is monitor respiratory rate. Second is seeing the SpO2 and ABG level to assess acidosis, alkalosis. Check the chest expansion. Assess breath sound using stethoscope. Check the level of consciousness. Monitor vital parameters. And always inspect ET tube position and fixation, which is very, very important. Clear? Okay. Next is airway maintenance. So how we have to maintain the airway? Maintain patent airway is the ultimate goal for us. So we have to maintain patent airway. Perform sterile suctioning when required. How we have to do suctioning? It's a separate procedure. I will explain you it in the next session. A separate session on suctioning. Okay, so you have to perform sterile suctioning when needed. Why sterile suctioning? Why they have violated sterile suctioning? Since whatever we do, it goes directly into the lungs. If you perform any unsterile technique, what will happen? That may ended up in pneumonia or some sort of atelectasis, some sort of other respiratory conditions. Okay, so we have to follow sterile suctioning process. Then ensure proper ET tube fixation, monitor cuff pressure, which already told, and provide humidification. Always we have to provide humidified oxygen. So using all these techniques, you will have to maintain the patent airway. So in this picture, it is very clear. So this is how a patient will be like, and this is the ET tube, and this is the position they fix. Okay, some sort of anesthetist will tell, maybe 28 or 18 centimeter or 23 centimeter, they will put this plaster and secure it over the patient's cheek. You have to check at regular intervals whether that position is incorrect or any pull out is there, any chances of out is there, or any the tube has gone inside. All those things you have to, at every possible time, you have to check for this position and the cuff pressure. So how we have to maintain airway? We have to through proper sterile suctioning, proper ET tube positioning, and maintaining cuff pressure and providing humidification. Okay. Next is monitoring the ventilated parameters. So as I have already told, there are so many settings which is available in ventilator. So what are all the settings? One is tidal volume. All these parameters will be taken over by the anesthetist. Just we need to have a thorough knowledge about the terminology part. Tidal volume. This is the tidal volume which will be set by the anesthetist. Respiratory rate. Say for example, the normal respiratory rate is 12 to 18. So the doctor will set, the anesthetist will set either 12 or 14 in the ventilator. That rate of breath only the machine will give. So respiratory rate. Third is the FiO2, inspired oxygen, fraction of inspired oxygen. We will not tell 4 liter, 5 liter in the ventilator setting. We always tell FiO2. So 50%, 40%, like that we used to tell. P, positive end expiratory volume or the pressure. Then peak airway pressure. These are all the different vital ventilator parameters with the setup which will be available in the mechanical ventilator. So next is the infection prevention part. Again a very, very important aspect. So first and foremost is follow VAP bundle. What do you mean by VAP? Ventilator associated pneumonia bundle. So we have intubated the patient. We have put the patient on mechanical ventilator. What will happen? Some sort of external tube is lying inside the patient lung, right? So the chances of the patient going into pneumonia or the chances of pneumonia is high. The incidence will be very high. So we have to prevent that pneumonia, ventilator associated pneumonia. We have a bundle for that. Bundle means what? The preventive aspect, the prevention aspect. So what are all the VAP bundle here? Hand hygiene. We have to follow strict hand hygiene technique. Oral care with chlorhexidine. Very, very, very important. So if the patient is on ventilator, definitely we have to give oral care with chlorhexidine. At each shift we have to give the oral care. Then elevate the head end of the bed 30 to 45 degree. What will happen? Why we need to elevate the bed to 30 to 45 degree? because the maximum lung inspection will be there and there will not be any lung congestion or what to say, atelectasis, that and all we can able to prevent. Okay. Then daily sedation vacation. What do you mean by sedation vacation? We have to withhold the sedation for some period of time. For say for example some 5 minutes or 10 minutes, how the patient is responding. We have to assess that. And then peptic ulcer and DVT prophylaxis, very important. For stress ulcer prophylaxis, we have to put the patient on pantoprazole or omeprazole etc. in injection format. And for DVT prophylaxis, we have to make the patient to wear some elastic TED stockings for prevention of DVT. Because if the patient on ventilator, they will be on bedridden period. So what will happen? Venous stasis in the lower extremity will be there. In order to prevent that, as a part of DVT prophylaxis, we have to start the patient on Clexane and put the patient on elastic TED stockings. These are all the preventive aspects for ventilator associated pneumonia. Okay. So infection prevention, we have to follow VAP bundle. Once again I repeat. So what are all the things you have to do? We have to follow hand hygiene. We have to do oral care with chlorhexidine. We have to make the head end to be elevated to 30 to 45 degrees Celsius. And daily sedation vacation. You have to withhold the sedation for some period of time in order to assess their lung capacity. And definitely we have to start the patient on peptic ulcer and DVT prophylaxis. Clear? Okay. Next is patient comfort and sedation. So patient will be feeling like very painful in the ventilator thing. So what we have to do? We have to administer sedatives and analgesics as prescribed. We have to give the patient on sedatives and analgesics as per the doctor's order. Provide reassurance and communication. I just want to highlight this word. We have to provide reassurance and communication. Though the patient is on ventilator under sedation mode, we have to go and talk to the patient. Whatever procedure we do, whatever say for example, if you are going to do any suctioning or if you are going to do any ABG sampling, we have to definitely go and talk to the patient. Madam, we are going to do some sort of suctioning to you so that we will remove the secretions from your lungs. I am going to take the blood sample so that the blood reports are okay. We will be slow by slow, we will be weaning it off from the ventilator. Or each and every aspect we have to go and communicate to the patient, though the patient is on sedation or not. Never mind that. Okay. Provide reassurance and communication to the patient. Maintain comfortable position. Prevent anxiety and agitation. So some of the ICU patient will behave in a different manner. So in order to prevent agitation, we have to keep explain each and everything to the patient. Make them relax, calm down, sir. Please don't worry. We all are here with you. Just cooperate with us. We will be making you to go to the next level and you will be having a speedy recovery. Like that you have to go and communicate to the patient, though he is on ventilator support also. Clear? So that adds more value for the patients. So preventing anxiety and agitation plays a major role. So that actually aids in faster extubation. Okay. Next is what? Nutritional support. So very important, because if the patient is on ET tube under sedation, where will the patient will take the food? Just imagine, only the IV fluids will not give any sort of strength to the patient, right? So we have to start enteral feeding via NG tube. You can very well ask the doctor. Doctor will be intubating the patient and she will just move off. You can definitely, very well you can go and ask the doctor. Doctor, why don't we start the patient on RT feeds, NG tubes? We will put the NG tube and can we start the enteral or parenteral feed, like that you can ask. Okay. So you have to start enteral feeding via NG tube. Monitor aspiration risk. Maintain proper feeding position. Monitor fluid balance. Again, a very important thing. So you cannot go and give the fluid as like you want. No. So you have to maintain the fluid balance. If the doctor orders tells you to give 2 liter or 2.5 liter per day, divide this 2 liter or 2.5 liter into 3 shifts and administer that particular amount in each shift. You have to make sure that particular that particular ml is covered in each shift, so that the entire 2.2 liter or 2.5 liter will be covered for the whole day. So you have to maintain the fluid balance. Clear with the nutritional support? What you have to do? You have to start the enteral feeding. While feeding, you have to be very careful to prevent this aspiration risk and maintain proper feeding technique. Usually the semifowlers and fowlers position will be ideal thing while doing feeding, and monitor the fluid balance. Okay. Next is again skin care and positioning. You all will be knowing, no, if the patient is on ventilator support or patient is on bedridden for a longer period of time, what will happen? definitely the chances of pressure injuries are more. So in order to prevent that, you have to turn the patient every 2 hours. 2 hours once you have to change the position of the patient. Some hospital will follow the protocol of position clock. At 8 o'clock means all the position will be lying in supine position. 10 o'clock they will be turned to semi-fowlers. Then maybe 12 o'clock they will be changing the position to right lateral, then left lateral. Like that they will follow the position clock across the hospital. That's also one way of good thing to prevent hospital acquired pressure injuries. So you have to turn the patient every 2 hourly. Prevent pressure injuries by following any sort of advanced dressings are available nowadays. So in case of high risk patient, we can put some sort of devices like advanced dressings and all in order to prevent pressure injuries for high risk patient. Maintain proper body alignment. Where and all the pressure points is there, we can just put some sort of cushion or gloved bag, some sort of other cushioned bag we can apply on the pressure points. Provide eye care and mouth care in order to make the patient to feel like good. Okay, so what is the last part? We have come to the last part, that is complication of mechanical ventilation. So each and every procedure has got their own complication, right? So we have a complication for mechanical ventilation as well. One is the VAP, then barotrauma, that is any injury in the lung cavity, O2 toxicity, hypotension, airway injury, and ventilator dependence are some of the expected complication of this mechanical ventilation, and we have to play an important role in order to prevent each complication at the maximum. Okay, so when we can wean from the ventilator, we have to assess the readiness of our weaning, gradual reduction of ventilator support, monitor the respiratory status, perform spontaneous breathing trials. What do you mean by that? We have to put the patient on pressure support mode, whether the patient is tolerating or not. If the patient is tolerating, we can just wean it off and extubate it. If the patient is not tolerating, again we can put the patient on SIM mode. So we have to give some sort of breathing trials in between in order to make the patient to extubate from the ventilator. So what is the role of nurse? We have seen so many aspects: ventilator aspect, respiratory aspect, nutrition aspect, skin care, and all those tips. So we play a major role in carrying a patient in mechanical ventilator. So we have to follow that. Okay, so you have to make the patient, we have to monitor the patient continuously. We have to, as much as possible, we have to prevent the complications being in ventilator. Always we have to maintain a patent airway, assist in weaning process, and psychological support is very, very important. We have to follow this psychological support for faster recovery and outcome. Clear? So to conclude, mechanical ventilation requires continuous monitoring and skilled nursing care. Proper nursing can help improve patient outcome and reduce complications. Hope this session is useful to you all. So in this session we have learned different sort of ventilator setup and what all the parts will be available in the ventilator and what all the nursing care we have to give for a patient in ventilator and all the other expected complication and how we have to prevent that. Hope this session is useful to you all. So do subscribe our subsequent videos. Thank you.